Hi there, my name's Dr. Nick Weaver. I'm just going to present a brief 10 to 15 minutes presentation really on my thesis, my PhD, and the study that was involved with that. Thank you for this opportunity to present on my work of about 3 or 4 years at this conference, which I shall do now, try and sum up as much of it as I can in the course of the next 10-15 minutes. So without further ado, there's the title of the thesis, Experiences of Care Continuity and Recovery for People at the Interface of Primary and Secondary Mental Health Care in Wales, a thematic discourse analytic approach. And I'll really unpack that title and much more over the next 10-15 minutes. You can see that on that slide, my ResearchGate profile page. So please feel free to go and have a look there, find out more about my work and find out more detail than you'll be able to find out from what I can pack into this talk. Just quickly introduce myself. There's a nice photo of me there, hopefully a nice photo. I'm a mental health nurse, trained at Swansea University. Clinical experience is really in acute psychiatry, real interest in psychotherapeutic approaches, and also substance misuse and addiction. And this really led to an interest in recovery, what recovery means, what recovery can be, in not just in a substance misuse and addiction context, in many contexts of mental health. So I'm now at Cardiff University and lecturing there. Just an outline of the PhD project. The aim was to investigate experiences of care continuity and recovery for people moving across the interface of primary and secondary care, and largely to do with service users who had been discharged from specialist care to the GP, perhaps with the opportunity of going back again, but this movement had occurred across that interface. What were their experiences like of recovery? Was there disruption to the continuity of their care? These are the sorts of questions that I sought to find out answers to in the course of my study. And really, in this talk, I'd like to focus on recovery. So I'll just briefly introduce the concepts as best as can be done. And you have there, you can see the traditional, if you like, Oxford Dictionary standard definition of recovery as cure. Well, the idea of recovery in mental health is perhaps quite different to that. And a famous quotation is there from William Anthony. Have a look at that. You can see that certainly doesn't mean that you're necessarily cured. It may be a journey throughout the course of life where you would learn to actually have a full life in spite of the continued existence of mental health problems. And here you can see there are a number of ideas about what recovery is. It could be a holistic approach, seeking to provide care and treatment to all aspects of the person. It could just be a meaningful journey through life in spite of the limitations caused by illness. And really want to just draw out a contrast there, which has been described by Recovery in the Bin, for contrast between grassroots recovery, bottom-up recovery from the grassroots level of the service user, which may well have to do with the idea of becoming freed from coercive and even iatrogenic services, and this idea about emancipation and freedom and putting the service user in charge, empowering the service user, helping the service user to self-manage is a strong theme within ideas of recovery. Now, against that, there's this idea of recovery which comes from the policy level, is implemented in policy, and policy in many countries around the world has been very influenced by this notion of recovery. And the critique that's come from many people, including Recovery in the Bin, is that actually this idea of recovery, of self-management, has been taken by policymakers and used as a reason to say, well, you're now an empowered person, you can manage yourself, you'd be better off without services, which actually are part of the problem. So let's take services away from you and let's cut costs in so doing. So that can be driven by neoliberalist ideology and the ideas of cutting costs, austerity, getting people back to work. And so Recovery in the Bin, and I'm very influenced by their ideas, have coined the term neo-recovery, combining recovery with the first bit of neoliberalism to create this idea, in contrast to grassroots recovery. And this is an idea which I really picked up in my analysis. Just to say, David Pilgrim has called recovery a polyvalent concept. And one may wonder, well, actually, does recovery have a fixed meaning? Or is it actually a label which can be used as a term for a multiple number of activities and agendas within mental health, and just the term actually is used for all of those activities? Just want to say a little bit about the policy context of my inquiry. It was very much done in Wales, and that's a devolved healthcare administration. And Wales is quite unique within the UK in that they have used policy and legislation in the form of the Mental Health Wales Measure 2010 to really implement change in services and drive the nature of services. And this policy is very much underpinned, supposedly, by recovery values. Well, what kind of recovery values? Grassroots recovery values, or top-down, neo-recovery values? Well, I think the quotation there says that discharge from specialist care, this is taken from various pieces of Welsh Government literature surrounding the policy, that discharge from specialist care is regarded as a key outcome of the recovery model. So the idea very much with the measure is that you are discharged to primary care and you can be more self-sufficient in that context, and so you don't need secondary services anymore. Well, that sounds a little bit like neo-recovery. But I wanted to investigate, among other things, whether this kind of thing was the case. What kind of recovery experience and care continuity experience were service users having? So really just focusing on the methodology that I employed for the study. It was a qualitative study. I used in-depth semi-structured interviews at 2 stages, firstly with 16 service users and then with 16 workers involved with service users who fitted the inclusion criteria. And data analysis involved interview transcripts that were subjected to thematic discourse analysis, which is a combination of thematic analysis from Brown and Clark and discourse analysis. Discourse analysis fitted in really well with the constructionist philosophical underpinning, which I employed, really looking at the way in which people use language to construct meaning, to position themselves in relation to the meaning that they construct. And there was a real influence of Leclerc and Mouffe's post-structuralist discourse theory, which looks at discourse as an ongoing discursive struggle between individuals and groups attempting to fix key meanings. So my findings could be divided up into 3 themes. And the theme that I really want to focus on in this presentation is that participants constructed multiple competing versions of recovery in their talk. And this really led me to use the concept of a floating signifier from Leclerc and Mouffe to support the idea that recovery, which really was a polyvalent concept, is a concept. A floating signifier is a sign whose meaning has not been fixed, and this ongoing discursive struggle of parties and groups are seeking to fix the meaning of this sign of recovery. Participants' expectations were also misaligned with transforming service structures, particularly in view of participants not wanting to be discharged or wanting to get back into secondary services or have a CPN and finding themselves in primary care. And they weren't always very happy about this. And the third theme, which really was generated, was to do with care discontinuities, which were talked about in a variety of forms and were concentrated at the primary level of care. So I really went into a process of theoretical generalization for the discussion, using the theory of the floating signifier from Leclerc and Mouffe, and also complex systems theory, which really drew from the social systems theory of Nicholas Luhmann, and also papers by Hannigan and Coffey. describing that mental health services are as a wicked problem, and that attempted solutions to mental health services can actually just make things more complicated, can generate waves of consequence. And this was what I theorized, was that competing versions of recovery has actually become a factor for escalating complexity and fragmentation and discontinuity between sectors and services and individuals within services, supporting Helen Gilbert from King's Fund's argument about fragmented, escalating complexity of services. And I sought to describe this based on findings and analysis with this diagram there, which hopefully you can see. And I really argued that the mental health Wales measure in seeking to implement recovery-based services, or perhaps I should say neo-recovery-based services, and actually acted as a catalyst for escalating complexity because of competing recovery versions, misaligned service expectations, and also shifting roles and responsibilities and relationships between participants. And I had one participant, a GP, who really talked about a lack of clarity about his role and the role of secondary services in terms of cooperation for providing care for individuals, for his patients. And so there was this picture of fragmentation which emerged from analysis, and really also the contrast between neo-recovery and grassroots recovery was very, very much there in the analysis. And there are participants who spoke about various forms of grassroots recovery, but also there was this theme of neo-recovery and people being discharged to primary care, people feeling that they needed to get back to work. And so I brought in a further level of analysis drawn from the philosophy of Jürgen Habermas and his theory of communicative action, and his contrast between strategic action and communicative action, the systemic sphere and the sphere of the life world. And I thought that this was a really good way of understanding the contrast between neo-recovery, governed by neoliberalism, the systemic sphere, and grassroots recovery, which has much more to do with the life world of the individual service user. And so I brought that into play and really developed perhaps quite a post-Marxist view of recovery in my thesis. This had already been begun with Leclerc and Mouffe and their famous post-Marxist theory. But as much as their post-Marxism talks about discursive struggle between different groups and the political aspect of that, the real contrast with Habermasian post-Marxism is between the system and the life world, and the idea that the systemic sphere is actually colonizing the life world. And so I use this understanding to broaden the understanding of this understanding of recovery being colonized or co-opted, and that really, particularly in terms of neoliberalism, that this is what is happening. And actually, potentially, this is happening with a lot of policy versions of recovery, including the measure. And this gives rise to a narrow, perhaps impoverished idea of recovery, just about taking services away and cutting costs. And that this also becomes a factor for escalating complexity, because Habermas certainly spoke about the way in which the systemic sphere is tremendously complex in modern mass society, and the designification of recovery, whether the true meaning of recovery is somehow lost. And this has led, so just speaking about, as quickly as I can, about potential solutions and ways forward from this recovery in the bin, perhaps want to lose the whole concept of recovery. But I really argue that the concept of recovery could be reclaimed, that it's an important concept. And that really the problem is that the systemic sphere has become overly dominant, and that this has led to complexity and an impoverishment of recovery. But at the same time, too much bottom-up grassroots recovery, too much proliferation of different ideas about recovery is also a problem. And really, I argued in the end for a balancing of top-down and bottom-up recovery, a balancing of neo-recovery and grassroots recovery, the system of the life world, which Habermas certainly argues for, that we can't have everything in the realm of the life world, because society, we have to accept a degree of complexity in modern mass society. And that actually, Kim Hopper actually speaks about a working misunderstanding of recovery between the right and left, between a bottom-up notion of recovery and a top-down notion of recovery, and that this really could create a balance and a way forward for recovery. And so just finally, really it was quite a critical psychiatric perspective that I argued for. I mean, the difference between critical psychiatry and anti-psychiatry is that whereas anti-psychiatry argues for getting rid of a biomedical dominance, critical psychiatry accepts that there has to be some dominance of a biomedical perspective, or in this case a neoliberal element, but that should not be allowed to become overly dominant. And so really things such as local primary mental health support services, which are implemented by the measure, could be a good thing, and allowing third sectors to freedom and room to nurture recovery versions, and that we should not rely overly on policy and legislation to implement recovery, but we should actually restrain policy implementations and give room for grassroots recovery to be nurtured and to rise from the bottom up. And this was actually, in many ways, my fundamental thesis. So thanks for listening, and look forward to seeing you in the upcoming discussion. Thank you.